He had run that route 400 times. He knew every turn, every incline, every tree that marked the halfway point. He never reached it that morning. 35 years old, a structural engineer, fit, non-smoker, no history of heart disease, no family history he was aware of, no warning. The cardiac team that received him ran every standard test: echocardiogram, ECG, troponin, coronary angiogram. The coronary arteries were clear, no blockage, no acute clot, no evidence of a heart attack in the traditional sense. And yet, he had been 30 seconds from death on a quiet road on a Tuesday morning. What the investigation that followed when revealed had been present in his body since before he was born, something that had been quietly changing the architecture of his heart, year by year, millimeter by millimeter, while he ran and walked, and had annual health checks that always came back fine. The most dangerous conditions are not always the ones that announce themselves. Sometimes they grow in the silence between heartbeats, building, restructuring, waiting, until the body can no longer compensate for what has changed. The story of his heart did not begin on that Tuesday morning. It began decades earlier in a gene. Hypertrophic cardiomyopathy (HCM) is in the majority of cases a genetic condition caused by mutations in the genes that encode the proteins of the heart muscle's contractile machinery. In most inherited cases, it follows what geneticists call an autosomal dominant pattern, meaning one copy of the altered gene is sufficient to produce the condition. If one parent carries it, each child has a 50% chance of inheriting it. In the vast majority of people who carry this mutation, the heart does not look different at birth. The change comes gradually. The wall of the left ventricle, the chamber that pumps blood to the entire body, begins to thicken. Not all at once, a millimeter here, a millimeter there, through childhood and adolescence, often producing no symptoms whatsoever. He was active as a child. He played football, he cycled, he ran. He was occasionally breathless in ways that seems unremarkable. The breathlessness of a child who pushes hard. Nobody suggested a cardiac ultrasound. There was no reason to. That is not a criticism. There is a nature of a condition that does its works in silence. The heart was changing, the body was compensating, and between the two of them, they kept the secret perfectly. Through his teens and 20s, he experienced occasional episodes. He filed under the category of pushing too hard. Brief dizziness after intense exercise. A moment of lightheadedness that cleared within seconds. Once in his early 20s, a sensation in his chest during a hard uphill run that he described to a friend as his heart skipping a beat. He mentioned it to his GP at his next appointment. The resting ECG was normal. His blood pressure was excellent. He was told he was in outstanding cardiovascular health. And here is where this investigation must be precise. Because the ECG was not wrong, the blood pressure reading was not wrong, the GP was not wrong. Hypertrophic cardiomyopathy does not always produce abnormal findings on a resting ECG. It does not always cause symptoms at rest. The investigation that reveals it, a cardiac ultrasound measuring the actual thickness of the heart wall, is not a routine test. It is ordered when there is a clinical reason to suspect something structural, and he had never given any physician a reason to cross that clinical threshold. The thickening continued. In medicine, the absence of a finding is not the same as the absence of disease. Sometimes it simply means the right question has not yet been asked. What happened on that Tuesday morning was the consequence of a structural change that had been building for 3 decades. The thickened left ventricular wall had over years altered the mechanics of the heart. The chamber had become stiffer, less able to fill efficiently under the sustained demand of intense exercise. The electrical system of the heart navigating a muscle architecture it had spent years adapting to produce a lateral arrhythmia. Ventricular fibrillation, a chaotic electrical storm that converts the heart's rhythmic pump into something that can no longer move blood. A neighbor who had been leaving for work witnessed the collapse. She had completed a CPR course 6 months earlier. She started compressions within 90 seconds. The defibrillator arrived with the ambulance 8 minutes later. He survived. The echocardiogram performed the following morning showed a left ventricular wall significantly thicker than normal. The finding that would have changed every conversation about his heart. For the previous 15 years, the heart had been carrying this its entire life. It has adapted, compensated, and continued. Until the morning, the demand exceeded what the adaptation could sustain. Hypertrophic cardiomyopathy affects an estimated 1 in 500 people worldwide. Most of them do not know they have it. Research published in peer-reviewed cardiology literature confirms that approximately 17% of HCM-related sudden cardiac death occurs in individuals without a prior diagnosis, meaning the collapse is often the first indication that anything was wrong. This is not a failure of medicine in the individual case. It reflects a condition common enough to affect millions, but specific enough in its investigations that population-wide screening remains an active area of clinical debate. What is clearly established is this: family history is the most important clinical indicator. Approximately 60% of HCM cases have an identifiable gene mutation, and first-degree relatives of affected individuals carry a significantly elevated risk. His father had died of an unexplained cardiac event at 47. It had been attributed to stress, to the era, to things that happened to men of that generation. Nobody had suggested cardiac screening for the family. A parent or sibling who experienced sudden cardiac death or unexplained cardiac event, particularly at a young age, is precisely the family history that current guidelines identify as a clinical indication for cardiovascular evaluation in first-degree relatives. If that description fits someone in your family, a conversation with your physician about cardiac evaluation is appropriate. Not urgent, not alarming, a conversation. The family history is not just a record of the past. In medicine, it is sometimes the most precise prediction of the future. If someone thinks to ask the right question about it, he received an implantable cardiovascular defibrillator, a device that monitors the heart rhythm and delivers a control chart if a life-threatening arrhythmia is detected. It continues under specialist care. His 2 children have been referred for genetic counseling and cardiac evaluation. That referral may be the most important thing to come from a Tuesday morning on a road that almost had a different ending. It described his heart differently after the diagnosis, not as something that had failed him, as something that carried a structural difference for 35 years, compensating, adapting, persisting until the morning it could not. He said he no longer thought of it as a betrayal. He thought of it as information he finally had. Inside every one of us, the heart beats approximately 100,000 times a day. Most of us never listen to it carefully enough to notice anything unusual. And for most of us, that inattention is perfectly safe. For a small number of people living inside a structural difference, their body has been quietly accommodating for years. The most important investigation may not begin with a symptom. It may begin with a name in a family tree. A father who died too young, a sibling who collapsed without warning, a history that was always there, waiting for someone to finally take it seriously. The investigation continues. It always does. In the next episode of Medical Mysteries, a 41-year-old woman visits her doctor with one complaint: tiredness. Her doctor runs a standard blood panel. One result comes back abnormal. Her doctor notes it, attributes it to the tiredness, moves on. 8 months later, she is in hospital, and the abnormal result documented, filed, connected to nothing, is the first thing the admitting physician asks about. It had been there all along, waiting for someone to ask why. If you enjoyed this video, do well to subscribe, like, comment, and share. See you in our next episode.